Gibby's slide up? The first slide. Let me just, hold on, let me just. YouTube. You have 40,000 viewers on YouTube.
I see.
Okay, so. All right, great. It is a great pleasure and honor to have Professor Gibby with us, who is the chairman and CEO of Novarad. And in this convention, we have pioneers giving a keynote lecture, and I'm in awe of amazing accomplishments by Dr. Gibby in bringing amazing neuroradiology technologies to many millions of people, patients. But today he's going to grace us with a new immersive technology and mixed reality that is just unbelievable new generation of intraoperative navigation with mixed reality. Is that correct? So thank you very much for being here, and pleasure to have you. Pleasure.
Babak, thank you. I have to say that Babak Kitab is a force of nature, really. I mean, to try to bring this thing together, it's amazing. So we're kind of near Hollywood, so I'm going to tell stories today a little bit. I'll focus on some of the more technical aspects of this technology in another session, but I'd like to just take you through a journey. As a medical student at University of Utah, my first year, I witnessed something called a pneumoencephalogram. Some of you may be old enough to remember pneumoencephalography. So this is really a journey of one generation. In internship at LA County, Harbor General, we had a second generation CT scanner. It took about an hour to do a single study. From CT, we moved to MRI, and MRI became a very transformative technology to allow us to see with improved soft tissue contrast. In this patient here, the CT is virtually normal, but there are severe diffuse axonal shearing injuries in this brain. From there, we moved into taking data sets and doing advanced processing with these, like three-dimensional imaging, and then teasing out other functional information, whether it be tractography, perfusion imaging, et cetera. So this revolution of imaging that began with plain X-ray has gone all the way from simple two-dimensional studies to some pretty amazing imaging. The next phase of this journey is augmented reality. And in this case, we are able to take high-resolution three-dimensional imaging data structures and precisely co-align that to the patient's head and use it for operative guidance. So we're gonna talk about this journey, and hopefully we'll get a chance to kind of see the roots of this here. This began a little bit humbly, I guess. I had finished a fellowship at University of Pennsylvania. I came back to my hometown in Provo, Utah. I started a little company building coils for MRI machines just because I was too dumb to know any better. Had a friend who was an engineer, and he proposed that he could make these coils that we couldn't get. And I had a chance encounter with a patient, Joe Parkinson, who was the founder and former CEO of Micron Computers out of Boise, Idaho. And he was a fellow I treated a little bit, and he took me to lunch one day, and we chatted, and I had this really miserable little company that wasn't amounting to much, and very supportive, and gave me some really great advice. At that time, we were a small company with 3 people. We had, this was a low-rent area across from the state liquor store and next to Buffalo's Termite. We had a hair parlor behind us, and it was very hard to attract and keep employees. At that time, we were building surface coils for MRI machines, and this is the world's only phased array quadrature breast coil. Now they just do them with phased array. But we weren't very successful. One of my employees at the hospital had seen a little sign at a bank, and you've probably seen this on the internet, but I had her paint a picture of this for me, and I hung it in the office of that humble little first business that we had. And that was our motto, that we would never give up. I had a sign actually as a young man that hung in my room from Calvin Coolidge that said, "Persistence alone is omnipotent." And we kept going. Now, we were up against some pretty big companies, General Electric, Siemens, Philips, Carestream, etc. But we persisted. There was a young man who came to me. He was doing a PhD in electrical engineering at the local college. He had come from Hong Kong. And he had met with a computer science, former computer science guy that was a pathologist, and he said, "Well, I'm not doing anything, but Gibby's kind of crazy. Go to radiology and talk to him, because he's always got some project." This engineer was looking for work, but he wanted a specific kind of work. He wanted a green card, because he did not want to go back to Hong Kong. In Waiho, I didn't know any better, but he really didn't know how to program computers. He knew how to engineer chips. That was his background, was in doing, he had reverse engineered the Z80 chip in China, for example. But I thought, okay, sure. Can you program my Macintosh to get images to my house at night? And he said, "Sure, I can do that." And he picked up the books that were like telephone book thick of Macintosh programming, self-taught himself to program, and wrote the first teleradiography program that we had, which was TeleradStat. At that point, we had a choice, and we decided that we would get out of the coil business, and we moved into the electronic imaging. The problem was we didn't have any money, and when you don't have money and you're trying to build a company, no one wants to talk to you, because they only want to invest in something that's already succeeded. The other problem is, if you happen to get money, you basically lose control of your entity. So we bootstrapped for many years. And because of that, we had to learn to control our expenses and to be very cheap. Now, this was our laptop computer back in the day, and we would literally carry this on the plane like this. It was some duct tape that we would carry and stick in the overhead bin, because we were too cheap to buy a laptop. I was an interventional neuroradiologist. I made plenty of money, but like Shaq O'Neal has said to his children, "I'm rich, you're not." And this was the problem with young companies. My partners at the RSNA would stay at the Ritz-Carlton. I would stay at the Essex Inn. Now, because this is Hollywood, I'm going to tell you a story. You won't believe it, but it's true. Waiho Poon was a young student, and we had the rest of the company here. We were staying on about the 5th floor of the Essex Inn in Chicago. This is early December, freezing cold. There's a crack of about a half an inch between the window, so this cold air is rushing in, and there are 6 of us sleeping in the same room. Waiho Poon is hungry, so he goes down and buys a half of a chicken, or the whole chicken, actually, and then he hung it out the window that night in order to keep it cold so he could eat it the next day. So the joke became that everybody wanted to be the guy to sleep on the floor, because I insisted that I would sleep on the floor, And then everybody else wanted, so for many years, we literally lived on a shoestring. But it allowed us to keep control. And we expected to fail, but we hoped to fail at a small scale, which is what we did. But being big is not necessarily better, because many times large companies struggle with innovation. I met with 3M at the time. They came and saw our operation, and they were astounded that we were even trying to do this. 3M is long gone from this business. So our model became innovate or die, and we've had a lot of innovative products over the years that has allowed us to be one of the industry leaders in the PACS archiving and risk market. From there, we learned how to do advanced image processing. And from there, we learned how to do things like artificial intelligence to segment structures and to do advanced rendering. And we took this segmentation and rendering technology and created new products such as brain atlases and functional quantitative analysis systems for the brain. And now I want to tell you about the rest of the story. This young man, Dr. Steve Savetko, was a pre-med student at the local college, and he also came to visit me one day. He said, look, I want to go to medical school and I need a project, and I will work for free. And I'm like, wow, okay, got it. So Steve he volunteered as an intern there at my hospital and our little company, and he wrote the first DICOM server in the world. This is before DICOM it was just barely coming out as a standard. And that's him in his college days probably talking to me. This is now, a recent picture of Steve. Steve went on to University of Illinois at Champaign-Urbana, one of the top computer science programs in the world, and University of Chicago for medical school. After about 3 months in medical school, he called me and said, this is the most boring thing ever. I cannot stand to sit and memorize. And I said, Steve, stick away. He's like, nope. And he did a PhD. Finished his PhD and was recruited by Google because he had done advanced image processing. But he couldn't afford to live in the Bay Area with 3 children. So he came to work for me. Fast forward 20 plus years, and Steve had begun working surreptitiously on this new augmented reality system that is now transforming what we do. So my goal here is to show you a little bit about this revolution. So this is essentially where you can see the patient, but you can see through them at the same time. And you're able to co-register this with millimeter accuracy to segment, to view these images on the fly from many different perspectives. Now, I'm not going to talk about all of the different registration technologies that we use. There'll be another talk in room 150A. I think it's at 1 o'clock, and I'll go through some of this. But suffice it to say, it's a technical challenge to get these images to align and to keep them aligned with human anatomy. The next challenge that we had to figure out was how do we render this in real time on a headset? With using Unity, which is many layers of abstraction higher, it's fairly slow, and you can't get the image-rich rendering with lighting and shadowing and so forth. And we created our own graphics engine to do this so that we're literally doing true 3D on-the-fly processing. These aren't 3D models, these are the actual DICOM data sets. Well, how accurate can we get? A paper that we published recently, our registration accuracy was down to sub-millimeter, and our accuracy for targeting structures is now down to about 1.2 millimeters with an angular error of 1.3 degrees. So that's close to what robots can do, and certainly as good as the best navigation systems out there. So AR guidance is going to allow for procedures that don't currently use guidance. And the reason is because of cost and inconvenience and lack of availability. So for example, just putting the patient on the table and getting them oriented correctly for the surgery, knowing where to make that optimal incision, doing a burr hole or a drainage in an ICU or putting in a ventricular catheter, those are not systems where you're going to use robotic guidance or navigation systems, but could improve the quality and the precision of medical care. So this is Dr. Mike Carsey. His first attempt, this is a paper we just submitted for publication on ventriculostomies. This is a 3D printed jello phantom, cranial phantom. In his first attempt, he was 4 out of 4 dead on to the ventricles. So we said, well, how much does experience matter? And we looked at a group of residents and trainees and postgraduate and attendings and looked at whether or not having experience doing ventriculostomies would matter. And what we found is that the augmented reality flattened the learning curve. So the first-year resident was as good as the 10-year attending. I'll just show you a few types of clinical examples. In the OR, it's hard to see through the ribs because of the overlapping structures. This is one of the first cases we did. We simply project the CT data set onto the patient, and the surgeon knows where to make the incision. Smaller incision, less OR time, faster recovery. How about the radiation issues in medicine, increasing significantly, especially in spinal navigation? This is a patient who was sent to me a couple of years ago who was fairly heavy-chested and had hypertrophied the posterior spinous processes, had a disc herniation. They wanted a thoracic epidural. I spent 45 minutes trying to do it, could not get in. Brought him back a couple days later, turned on the Visar system. We did a spin CT in our angio room. There's a little tiny hole just off midline that we found a target we could go through, line it up. We know exactly how to angle, guide it with the augmented reality headset, and in a single stick, we're in the epidural space. The radiation dose on the first procedure was 4 minutes, and we failed. The radiation dose on the second procedure with the epidurogram was only 1 minute, and we succeeded. Let's talk about this potential in other surgeries. Currently, pedicle screws are placed primarily in an open manner without guidance. Good surgeons do a great job, but bad surgeons, cause complications. So doing the open surgery on 66 pedicle screws, we had a 97% success rate. When we went to MIS guidance, where these are percutaneous, we're using like a Jamshidi needle and then following that with a K-wire and dilator, we're just as accurate using MIS. And MIS is not, doing an MIS procedure, you have to have some kind of guidance. You cannot do these like an open procedure. So in a case like this, a cadaver with 24 pedicle screws, we had 100% success rate, even with the patient rotated and scoliotic and fairly small pedicles. So our overall success with open and MIS pedicle screws, this data was just published in Spine, is over 96%. We can add to this optical code technology to track the tool, track the instrument, and let the surgeon see in real time, in virtual reality, where their instrument is being placed. So I can, so for example, in this cranial phantom, we're targeting a tiny 0.5 millimeter object near the clinoid, and I can see the images, but I can also see my virtual needle as I go in and approach the target. Our tool tracking now is down to about sub 2 millimeter accuracy, about 1.7 millimeters. And we have a targeting system both from down the barrel of the instrument and from the side where we can get fairly precise guidance. I think that the next really exciting part of this is the mixed reality, where we can fuse data streams from different types of technologies. So in this case, you see my hand, that's reality with a pair of ring forceps. I have the augmented reality, which is the patient which is a brain, where I've mapped or targeted the frontal language area. And then I have real-time fluoroscopy that's superimposed and being fused with the mixed reality. And this is all coming into me on a headset. The entire OR footprint is on my head. So VISAR is an end-to-end stack with a lot of technology that undergirds us. We have 33 years in the PACS business and doing things like auditing and sign-ons and encryption and AI segmentation and rendering, and then of course the technologies for registration and virtual guidance, and finally this immersive utilization. So it's not just a simple one-step system, but it is completely integrated from end to end, DICOM images to immersive reality. So I'm going to just show you a couple of recent cases that I think will be interesting to this audience. We've not made a lot of progress in cancer treatment, solid cancer treatment, in the last 40 years. And that's partly because these cancers aren't terribly sensitive to chemotherapy. Once a cancer has left the reservation, so to speak, it's hard to keep it under control. So this actually is some technology that has been worked on by Dr. Gary Onick, a colleague and friend of mine. The idea is to find the most metabolically active part of the tumor with PET scanning. We sublethally freeze it, which disrupts cell membranes, exposes antigens. We then infuse slowly immune modulators like checkpoint inhibitors, and we recruit the body's own immune system to fight the cancer, both locally and for metastasis. We're trying to train the immune system to go after the cancer. So here's an example where, I'm going to show you a couple of examples where augmented reality can have a pivotal role in helping to treat these. This is a patient with a poorly differentiated adenocarcinoma. The tumor is actually deep up near the diaphragm. It's next to the inferior vena cava, the aorta. It's behind the spine. To get to that is a complex procedure to be able to triangulate in 3 dimensions with CT. But with augmented reality, I can guide my needle down in these 2 planes, avoid the lungs, know my best entrance point, and once I'm close to the spot that I want to be, then I can double check with CT. So reduce the radiation and the procedure time by using the augmented reality to guide our system in. This was actually a case we did this week in Yerevan, Armenia, which involved cryosurgery of a glioblastoma. This young man, very bright guy, PhD, mathematician, had failed surgery, had failed radiation, and failed chemotherapy. And so basically limited guidance technology there, so we took the VISAR system, used it to pinpoint the exact area of the brain tumor that was the hottest on the PET scan, put a infusion catheter, a cryosurgical probe into this. We had another burr hole where we had a transcranial ultrasound, and you can see the cryosurgical probe and catheter is dead exactly where we wanted it in the tumor. First stick with the augmented reality system. We froze that. You can kind of see the freeze area on the right-hand frame, and then infused these checkpoint inhibitors for a couple of hours. I'm happy to report the patient survived. He's doing okay. We don't expect, we won't know for some time whether this is an effective method, but based on other efforts we've had in solid cancers, it holds a lot of promise. So in conclusion, I want to talk about guidance in general and some of the issues that have to do with current technology for neurosurgical and even other operative applications. Robotic guidance is expensive. A system is $1.5 to $2 million, not to mention the ongoing maintenance costs. It's not available in many places of the world. It requires extensive setup time and very specialized personnel. And unfortunately, each robot system is different, so it requires different training, different setup. And honestly, for most facilities, the return on investment just isn't there. Furthermore, robots are stupid. Despite all the AI that we give them, each human being is a little different. There's no tactile feedback like a surgeon would have. There's no experience built into that robotic arm. And even with AI, robotic surgery will be vastly inferior to the human capacity to adapt. So I think that this is going to be one of these transformative technologies where augmented reality will be disruptive and is going to change how guidance is performed in surgical aspects. And I'm going to conclude with a little mockumentary.
In a prehistoric world, dinosaurs and robots roamed the earth, lumbering along, large, unwieldy, and slow. It was a cumbersome age, bogged down by high cost and time-consuming OR setup. Stuck, searching for ROI, the robot, like the dinosaur, was doomed. Robot-assisted surgery faced extinction as more advanced technologies evolved with human-powered intelligence. Today, augmented reality's surgical guidance promises to lower cost, democratize access, shorten procedure times, and improve accuracy. The Novarad Visar system is the most advanced augmented reality system available today. In the end, Visar just may be the reason conventional navigation and robotic systems go extinct. But don't take our word for it.
Oh my gosh, this is a game changer. I can see boy, that made a huge difference.
This technology is developed. It's basically cleared already for preoperative planning and under consideration for intraoperative use. That's ahead of everybody else.
Amazing, dead center in the pedicle. So we had no learned tactile feedback to adjust our screw trajectory. It was complete faith in the system, and proof's in the pudding.
I think the sky's the limit for it. It's very impressive.
Visar from Novarad. It's time to focus on the patient, not a monitor.
Thank you very much. It's been an honor.
This here? Thank you. That was a fantastic talk. Can you reality? You talked about there's augmented reality, virtual reality. Can you explain how to navigate those terms in just as a physician, as a neurosurgeon, that I don't know where to draw the line, because it's obviously not reality, it's something else. So when you say augmented, does it fall into the same category as virtual, or are they synonymous, or they're not? Just wanted you to clarify that.
A lot of terms out there. So mixed reality, augmented reality are often used synonymously. Virtual reality implies that you're in an immersive, sort of like an Oculus environment, but you do not have reality interposed with it. In mixed reality or augmented reality, you have semi-transparent glasses and you're seeing the patient. You're seeing the world around you. It's not disorienting, but you're fusing other data in through your vision. So you see that brain lying there on the table, but you can also see the tractography. You could also see the virtual burr hole that you're going to do. You could see, you know, the brain MRI scan where you outline the margins of the tumor, et cetera. So the mixed reality is taking reality, what you see, and fusing additional information to it.
What an excellent talk. So really amazing work. The holy grail of intraoperative navigation really comes down to precision, right? So how do you get the right target? Because the image registration and the anatomical shift is an issue. So you may get the target right, but you know, when you start debulking the tumor, so how does your system actually adjust to that brain shift?
Yeah, that's a great question, Babak. The reality, to use a metaphor, is that there isn't a good solution for that yet. I think at some point we may be able to warp the brain data set from the MRI and warp it to the shift that's present there at surgery, but augmented reality only is as good as the data that you give it. So if the patient changes between when the image is acquired and when it's registered on the patient, yeah, it can be different. But it's still, I mean, it's a heck of a lot better than nothing. So,
no, it's fantastic. So the other question is that does your devices communicate with the PAC system, or you have to actually get the data into you know, certain hardware that you can use it? So how does that, you know, software-wise, how does that work?
Yeah, come to the next talk. It's a little more detailed, but the yes, the answer is there are 3 different ways to do that. You can import that via a jump drive or a CD. You can push that from a PAC system. You can query it from a PAC system. So any DICOM connectivity, any modality. And we also take, there's a wireless connection box, so we would hook that up to our angio system or microscope or ultrasound, and it allows us to stream those images in real time. In fact, we were talking to Olympus earlier about, you know, potentially getting their video stream. You can imagine the cadaver lab that we just saw, so now you could also mix in with that the tractography, for example, or, you know, an outline of where the tumor is that the doctor is searching for.
So the third question is that, well, we're all aware of tractography, fMRI, and so on, but there are multispectral imaging out there. So in what format do you have to get your data to be able to superimpose?
DICOM is how we typically handle it. I mean, we can convert image formats to DICOM, but DICOM's sort of the medical imaging standard.
Okay, but when you kind of transfer it to DICOM, wouldn't that drop the resolution?
It shouldn't.
Yeah. Okay. I have a project in mind. That's why I'm asking you.
Yeah.
Thank you. Any other question? All right. Fantastic.